around as much. And so all those things, as you become more sedentary, your circulation is not as good. And so the risk of blood clots is a little higher. But this is a complication that occurs with any surgery. And there's a number of things that we do to try to prevent it. Because obviously, if one of the possible outcomes is death, you want to try to prevent that. And the way we try to prevent it is we don't want the blood clots to form in the first place. So we'll use devices on your legs that pump the circulation. You probably maybe you've had those in the hospital before. We use blood thinners like heparin or something akin to heparin. He mentioned blood thinners a while ago. We do use some level of blood thinners, although not fully. We don't fully thin your blood because we want to stop the bleeding, but we'll give you enough to try to decrease the clot formation, okay? And that's what we call prophylaxis. The other thing that we want to do with our patients that are able is we want to get them up moving as quickly as possible. We want you up, we want you walking around, we want you using your legs to get your circulation going. So if we do all of that, then the risk of that blood clot is pretty low, but it's still there. Cardiovascular you see on there, I mean, you can have a heart attack, we mentioned that. And so one of the things that we want to do before surgery is we want to evaluate what your risk is there. And that may involve just doing an EKG and doing a general health assessment, or it may involve seeing a cardiologist, having a stress test, and maybe even a heart cath or something like that. But we're going to try to evaluate what your risk is before surgery and do the appropriate tests because we don't want you to have a heart attack either. Lap band. I'm going to cover lap band first. Most of the complications that are related to the lap band surgery are related to the fact that we're putting a device, implanting a device inside your body, okay? So you can see there on the list some things that we've already touched on. You can see erosion. Erosion means that the band puts pressure on the wall of the stomach, and then in some cases it will erode through the wall of the stomach, so that if you go in with a scope and you look from the inside, you can see the band, and that's not a good thing. A band erosion, while not usually a life-threatening complication, is a serious complication, and it does result in having to reverse the surgery, okay? That means the band has to be removed. But I will tell you that if you look at the 10-year studies that are out there, many of them from European countries, you will see that an average rate of erosion of somewhere around 2%, I'd say 1% to 2%. You'll see a few studies that's a little higher, and you'll see some that are lower. But I think if you average them together, you're going to see somewhere around 2%. The next thing on the list is band slippage. And I think most studies will show a little higher percentage or higher incidence of slippage than they will erosion. And I'd say that average these days is somewhere around 4%, maybe 4 to 5%, okay? Now band slippage, we kind of covered a little bit earlier, but a band slippage again is really not the band slipping so much, but really more the stomach slipping through it and slipping the part of the stomach that should be below the band, slipping through the band and coming up above, leaving you a bigger stomach pouch and putting some torque or some, changing the position of the band so that it may cause obstruction. So there's a very good chance that if the band slips or the stomach prolapses, would be another way to look at it, that you're going to have surgery to either remove the band or to reposition the band, so that you're going to take the band off, put it back on, and resuture the stomach and try to keep the band from slipping. You can have a problem with that port or the tubing that's connected. One thing that we have to do, remember, we have to put a needle into that port to adjust it. And so sometimes you can have needle sticks that will injure the tubing or I've seen cases where the little diaphragm the needle goes into will begin to leak after a number of needle sticks. If we use the right kind of needles, then that shouldn't really happen. The cases I've seen where that was a problem were from other doctors that used the wrong kind of needles. You see gastric perforation on there, and I think that while I haven't seen it, I've heard of it. I think there are two instances in which you can have a hole in the stomach. One is you can make a hole in the stomach putting the band on, okay? That should be a very rare complication. The other would be if you have a big stomach prolapse or slip in which the stomach gets obstructed, it could rupture and perforate itself. Again, that would be like having a perforated ulcer, and chances are you're going to have to go in and take the band out because of risk of infection and things like that. But those are both, I think, very rare complications. I have not seen it. And then we talked a little bit earlier about the possibility that the esophagus and that pouch can stretch or dilate. And again, that's most likely going to be a result of having the band adjusted too tight for a fairly long period of time. And it's something that I think that we have to try to avoid. And again, doing the adjustments appropriately is an important thing. And it brings up again, the limitation of restriction. Your body can only tolerate so much restriction. And if we adjust that band too tight, what's likely to happen is you're going to vomit a lot, which you're not really supposed to do. And if you tolerate that vomiting enough and don't tell me about it, I mean, eventually what could happen is your pouch or esophagus could begin to stretch out and dilate. So we try to, again, education is an important part, we feel, of good results. And so we try to educate our patients about, when to have an adjustment, what's appropriate. Sleeve gastrectomy, I think with time we'll learn if there are other complications, but as of right now, we talked earlier about there's a long staple line and the possibility of leakage. If you have a leak, you're going to get some infection from that, and we're going to have to treat the infection. We may have to go back in and do surgery. We may not, depending on the situation. If you have a little abscess, we may be able to put a little drain in there and drain it without going back in and doing surgery. But in the meantime, you may not be able to eat anything. We have to put you on IV and give you your fluid and your nutrition that way until the body has a chance to seal the leak itself, which it will do the majority of the time. You see nausea on there. I debate about whether I should put that on there because nausea is not really necessarily a complication so much as a side effect. But you can imagine, again, if we take your stomach and reduce the size of that by as much as 70 to 75%, it's going to affect the way you feel and when you eat. Bleeding, again, not that there's anything different about this surgery as far as bleeding, but we do divide a lot of blood vessels and we do divide the stomach, and the stomach is very vascular, so bleeding is no question a potential complication. We have to separate the stomach from the spleen. The top of the stomach comes very close to the spleen, so we can get into the spleen. That can cause bleeding. The spleen is fairly fragile. You see stricture on there. Stricture would be a narrowing. And even though we put a little guide down through the stomach, still after we staple along that, it could narrow at some point along there. And so we have to be pretty careful that we don't get too close to it. And I have seen at least one patient that we had to go in and take a balloon and stretch it out a little bit. But I see strictures much more commonly after gastric bypass than I do after this procedure. So I would say that stricture is probably not a real common problem, but it certainly is something that could happen. I think the complications that we see with gastric bypass and duodenal switch have a lot of similarities, so I'm going to kind of lump them together a little bit, and I'll tell you a little bit of differences, okay, as we go through it. But we have the complications just like the other surgeries that are related to the surgery itself and how we alter the body, okay? And so those are complications associated with the gastrointestinal tract. And then we have another group of potential complications because now these surgeries have malabsorption, right? And so then we have what we would call metabolic or nutritional complications that we see. So I'm going to cover those separately. If we look at the complications associated with the surgery itself and the gastrointestinal tract, you're going to see some things that are going to be shared and sort of similar with some of the other surgeries. You're going to see leak, okay? Anastomotic leak means it leaks where we put the things back together, okay? But it could leak from anywhere that we staple the intestine or suture the intestine. In the case of duodenal switch, there's one difference, and that is that when I hook the intestine back to the duodenum, that part, I don't staple. I don't use staples for that. I suture that. But basically, leakage could come from any place where we take divide the intestinal tract, put it back together, or staple it. Okay. You see stricture again. Again, that's a narrowing. And if you'll recall, on the gastric bypass, I try to make that opening about 12 millimeters in diameter. Well, that's relatively small, and the reason we make it small is because we don't want the stomach pouch to empty too quickly. We want to make sure that this point gets across. I always try to make it. The most common cause of strictures and ulcers after gastric bypass surgery, in my experience, is people who smoke, okay? And so for that reason, if you smoke and you don't intend to stop, I would recommend you consider a different procedure than gastric bypass. The other thing that could increase your risk of having an ulcer, and you see that a little bit lower down on the list there, would be taking medications that you know may cause ulcers, right? And I think you guys know what those are. I mean, aspirin and medications that are in that family. Motrin, Celebrex, what we call non-steroidal anti-inflammatory drugs. Those also increase the risk of ulcers. And I realize that a lot of our patients take those because they have a lot of back and joint problems. And we would like to get them off of it. We may not be able to, but we try to get them off as much as possible. You see on the list there below stricture, you see internal hernia. And that's something that you don't see often, and most people, it's kind of hard for me to tell you exactly what it is. Let me just tell you what it is. When we do change the intestine and we move things around, we create some little spaces that aren't normally there, okay? And if we don't close those spaces with suture, then part of the intestine can get trapped in there and it can get obstructed. So you see the next thing on the list, intestinal obstruction. So the most common cause of an intestinal obstruction after a laparoscopic gastric bypass or a laparoscopic duodenal switch would be an internal hernia. You see bleeding. The one thing different here about bleeding, again, we still have to work around the liver and the spleen and have to divide a lot of blood vessels, but one thing different here, as opposed to, say, sleeve gastrectomy or band, is that we are taking the intestine apart and we are hooking it back together. And occasionally I will see bleeding that occurs not on the outside of that, but occurs on the inside, meaning that I can't see it. And so I won't know that it's happening until maybe hours after surgery when the patient begins to pass some blood, usually through their stool. When it comes to malabsorption, this is something that a lot of people, some of you may have a real concern about. And it's a legitimate concern, but the only thing I can say to put you at ease on that is that in my patients, if they will take the recommended vitamins and supplements that we recommend, and if they'll come and see us and they'll get their lab tests done periodically, then our chances of having a really serious nutritional problem are very low. So you see anemia on there. That's most commonly from an iron deficiency. You see vitamin deficiencies. I will tell you that the risk is a little bit different for duodenal switch than it is for gastric bypass. Gastric bypass, the main ones we're concerned about are vitamin B12 and vitamin D. There can be others, but those are the ones that we monitor pretty closely. So there, all of the procedures require a certain amount of supplement and what I call monitoring. We do want our lap band patients to take a multivitamin. I don't, it's not as, maybe it's not as big a deal as it is with some of the other surgeries, but we still recommend that because they are going to have to alter their diet. And anytime you alter your diet, you may not be getting all the vitamins that you normally would. You may be eating less meat, so therefore you may not be getting as much vitamin B12 through your diet. And that's something that we'll individualize a little bit with each different surgery. Which vitamins you take, how many, and which lab tests we do afterwards. Okay, so the more malabsorptive the surgery, the more vitamins you need to take, and the more lab tests that we're going to do to test for deficiencies. And you see protein malnutrition on there. You have to take enough protein in. You need at least 60 to 80 grams of protein a day just to maintain your muscle mass. And some patients may need a little bit more. Certainly a more malabsorptive surgery like duodenal switch, you may need more protein than that. You may need 100 grams or maybe even a little bit more than that a day. So protein malnutrition is going to be a little higher risk with a more malabsorptive surgery. So these are the areas that we're looking at, and we're trying to monitor for nutritional deficiencies, and our goal is to try to minimize any nutritional deficiencies from any of the surgeries that we do. You see mortality rate of lap band about 0.1 to 0.2%. On yours, for gastric bypass, it probably says 0.5%. Well, 0.5% was a number that we always found for open gastric bypass. And what's interesting is that as we've gone to laparoscopic gastric bypass, the mortality rate has actually dropped a little bit, down to about 0.3% in most studies. So, I changed that a little bit to try to bring that up to date. One duodenal switch, about 1%. It's a more invasive surgery. Maybe you're selecting a little bit higher risk patient because we have more super obese patients. I can tell you that any risk and complication goes up generally as the body mass index goes up. The point I'm trying to make here, and the point I hope to get across to you, is that I don't see it as dangerous surgery, okay? And so I put these numbers up here, and I think that these are very fair numbers. I think they're numbers that if you really do a literature search and look for data, these numbers are numbers that you'll find. So 0.1 to 0.2% for lap band, 0.3% for gastric bypass, 1% for duodenal switch. And so if you look at these numbers, these percentages, and you compare to something like heart bypass surgery that has a mortality rate probably of about 2 to 3% in good centers, I don't think that you would necessarily conclude that bariatric surgery is dangerous surgery. Side effects are a little different. Complications, side effects are things that a certain percentage of people get predictably, and it doesn't mean that we did it, that anything went wrong. It just means that if we change, some things about your body, we expect certain side effects. But side effects generally would be things that would, the things that I've listed here would be generally classified as a side effect. We kind of talked about dumping syndrome. I don't think that I need to cover that anymore unless someone has any further questions about that. But again, dumping syndrome is really only associated with gastric bypass surgery. I don't see it with any of the other surgeries that we have. You see hypoglycemia on there. Well, I see that more commonly with gastric bypass as well, and actually hypoglycemia and dumping can be somewhat related. The way you metabolize carbohydrates and sugars is altered by the surgery. And so while someone may eat sugar or may eat a lot of carbohydrates, and they may not get dumping, what they may find is that they have a rebound hypoglycemia maybe 2 hours later. And that can happen now, right? I mean, maybe some of you experience that now, maybe some of you don't. But the reality is if you eat just sugar, there's a real good chance that a couple of hours later your blood sugar will drop. It's just sort of a normal reaction of your body, and that you're going to get hungry. And if you don't do anything about it, you could pass out. The way you deal with that is you try to avoid eating high carbohydrate meals without having other things that you eat with it. So in other words, you don't just eat a donut. I mean, you try to eat some protein with that, because proteins are metabolized slower and will help you maintain your blood sugar better. Flatulence refers to gas that gas buildup in your intestinal tract, and a lot of the gas that comes that you have in your intestinal tract comes from when you eat. You swallow air. Eat and drink some air, you just swallow air along with your food and drink, and that builds up. Now, most of the time, if you have a normal stomach, a lot of that you'll belch out. Like if you drink a carbonated beverage, right? You get a lot of that carbonation and you'll belch. Well, you know, if you have a small stomach and that carbonation goes right through the stomach into the intestine, like in a gastric bypass, you can't belch, you may not be able to belch it back out. And so you're gonna may have more gassiness and more cramps, and it may make you uncomfortable. So there's some things about the surgeries that certainly can, that you have to be aware of, and that you may have to change some habits to try to minimize those. We have some patients that have developed lactose intolerance. I would say this is going to be more gastric bypass, and maybe some duodenal switch or DS patients are going to have some lactose intolerance because of the way that they digest and metabolize sugars. So we have some patients that have to stay away from milk and milk products. Constipation can be a problem. I would say that that's often a result of drinking less fluid and taking less fiber in your diet. A lot of the foods that have fiber in them may be, when you have a restrictive surgery with a small stomach pouch and a small opening, whether it be band or gastric bypass or even sleeve gastrectomy, you know, some of the foods that you might normally eat that have fiber in them may be difficult. And so your fiber intake can decrease. And if that happens, then you may have more trouble with constipation. In the patients that do lose weight very rapidly, they may have what we call hair shedding. If your body will make some adjustments to prolonged weight loss, and one of the things that you may do is you will lose some lean body mass as well, and so your proteins are may be used for other things, and so therefore the hair may become brittle, and it'll break off. And generally speaking, after the weight loss stops and metabolism gets back more to normal, then those hair follicles are still there, they still have hair, but they become less brittle, and then you have less breakage. And I'll tell you right now that if you lose a lot of weight, you're going to have some loose skin somewhere. And it's going to vary from one person to the next as far as where how their weight's distributed. You know, youth has some advantages, but I mean, if you lose 150 pounds, you're going to have some loose skin, and that's just all there is to it. The difference between surgical and non-surgical weight loss really is the long-term results. And this results that these are results from Dr. Pori's back in the 1990s, in which he was doing gastric bypass, and he had over 600 gastric bypass patients and followed those patients for 14 years. And you can see that that he was able to establish very good long-term results. If you look at non-surgical treatment at 10 years, you have virtually no results. If you look at a group of patients who don't have surgery, and that was illustrated with the Swedish obesity study that was published about 3 or 4 years ago, in which they compared surgical treatment and non-surgical treatment, and they had a fairly large group of patients they followed non-surgical treatment, and at the end of 10 years, there was no weight loss. There's zero weight loss. There's a spectrum of surgeries, 4 different surgeries, that you have some that are less invasive and some that are more invasive, and that there is a difference in how effective they are. So if you see these percentages on this slide, what that percentage is the percentage of weight that you needed to lose. Okay. So what we call percentage of excess weight loss. So if you were 100 pounds overweight, how much did you lose? And so you can see that the average with lap band and sleeve gastrectomy is around 50%. If you look at gastric bypass, Roux-en-Y gastric bypass, you can see that's a little bit higher. And if you look at duodenal switch, it's higher still. And as I said earlier, the most invasive is generally the most effective. And there are studies, 10-year studies with duodenal switch, in which patients they have they follow patients for 10 years, they still have at 10 years over 70% excess weight loss, okay? So we still have to balance nutrition and health. I mean, we don't want to have weight loss at the expense of health, at the expense of nutrition. So we have to have this trade-off, and I think that these surgeries all balance that to some degree, and I think that one reason I like to be able to offer all of them is because I think different patients have different needs, have different desires as far as what they want, and so I'm able to offer them hopefully a procedure that meets their needs. The results you see here are also from Dr. Pori's work, and it shows for diabetes that up to 100% of patients are improved or resolved. I can tell you that if you look at resolve,